Okay, let's get started. I'm Bridie and I'm with my friend Joanna Tennent, and we get together every week, usually over coffee and a scone, and talk about the things that are on top and of interest to us. We both have a massage background. In fact, Joanna was my anatomy teacher when I first started training. And over the years, we've become good friends. And last year, we completed a 300-hour yoga training together. So we've kind of been in the same loop about stuff for the last year, chit-chatting in private about all things body and life. And what I thought we'd do today is just hit record on the phone and record a specific conversation that we're going to have. We've put a little bit of prep into this, but not a huge amount of prep about how the actual recording is going to go, so we'll just wing it. But the intention of this chat is to collate a lot of deep diving that Joanna's doing about a specific topic, which I'll introduce. I'll get Joanna to introduce, and to just have on record, I guess, some of the thoughts and processes that are going on with this specific topic, as it's not just relevant for me and Joanna, but it's relevant for the world. So, hello Joanna, would you like to introduce yourself and light touch, just talk a little bit about what we're going to dive into today and why?
Well, our topic today is osteoarthritis, and in specific, we're gonna explore hip osteoarthritis. I'm 64 and a half years old, although I don't feel 64 and a half years old to be. And a year ago, I was starting to notice hip discomfort. And so a friend of mine said that I had to go and get myself on the list for a hip replacement because you have to wait forever. And by the time you need it, you might be causing all kinds of damage to the rest of your body, or you might be on serious pain medication. So I went to my doctor midway through 2021, and he said to me, I said I'd like an x-ray to see what's going on. And I said, I know that there's not a strong correlation between x-ray findings and your pain experience, but it'd be quite good just to have it, so that in a year's time we could look and see if there's been a change. And he said, if I put you on the hip replacement list, and I said to you tomorrow, oh, you were number 1, would you have it? And I said, oh, no. I said no. But here I am a year later, and I go back to my doctor, and I say, actually, if you asked me that same question again, I wouldn't give the same answer. It's not that I want a hip replacement, but the experience that I'm having at the moment with my hip is that it's affecting my life, particularly with walking. I cannot walk much, and I like to walk.
So there's like a loss of activity. You're noticing a change of what you're usually doing. Okay, so I've got kind of a list of questions that I want to work through with you. These are sometimes, we've talked about these before in private, but I wonder if you can provide us with like just a light touch definition of osteoarthritis. What are we talking about when someone has osteoarthritis?
So, from my latest research into osteoarthritis, it is when the joint, a synovial joint, has lost its functioning, is not functioning well.
And by a synovial joint, we're talking about the main joints in our body.
Yeah, I think the common places are hip, knee, ankle, hand, and some spine. The mobile joints. Yeah. The mobile joints. Those mobile joints. Yeah.
Yes.
So, I am an anatomy teacher, and I really love the anatomy. So I have deep dived, to use Bridie's words, into understanding the pathophysiology. And because before I started to kind of really own the fact that this might be something I have, I fell into the same misassumption that it's a wear. I fell into that those words that are commonly used, wear and tear. And with those words, they're sort of unhelpful because they bring in the idea of sandpaper on bone, and that there's a wearing down, nothing you can do. It's irreversible, and it's sort of mechanical, and the cartilage basically breaks down, and then you got your bone on bone. So, but what I've discovered is that it's very much a biologically active disease. It is a disease, so it is a structural degeneration of the bone, but there's a biology underpinning it, and it's active. So there's a response of the body going on to something. What was your question?
That was perfect.
Okay.
And what you're giving me there is just the little window of, like, I agree with you, is when I used to hear the term osteoarthritis, I'd usually hear it or visualize bone on bone and a sense of the joint deteriorating. And one question that I had for you once I sort of learnt more about osteoarthritis is, why do we call it osteoarthritis? Because it seems like a big part of the pathology is about the cartilage degenerating. And so my question was, like, why don't we call it chondroarthritis, or a term that we would use to describe cartilage? It's not just bone, seems like it's cartilage. What's going on there? And you might have a fun fact for me.
If you were a shark and your skeleton was cartilaginous and you didn't have any osseous tissue, you're not at risk for osteoarthritis. So if you just have cartilage, you're not at risk for osteoarthritis. So to have osteoarthritis, it's really, to me, I think it's really pointing to not one thing, it's pointing to the complex of a joint. So that is cartilage, that is the bone, that is the synovium, and that is actually, it's also the muscles surrounding the joint. And cartilage doesn't have a good nerve supply, doesn't have a good blood supply, and it's not a pain-generating structure. So the association with the lived experience of osteoarthritis, not the structure, but the lived experience, is about pain and loss of function. And the pain is being generated in some of the other tissues because of that lack of a blood supply. Yeah, so not just the cartilage, it's a sort of like a response. And talking back to the biologically active idea about it, it does seem that people with osteoarthritis at a tissue level will have a change in tissue. All of the tissues will change. So in the cartilage tissue will change, and the cartilage tissue, like any tissue, is driven by the cells. And the cells in the cartilage change, and they start to express different molecules, and they start in different biomarkers or growth factors or things that actually don't allow the normal regeneration of cartilage. And then it seems to me that the bone, surrounding bone, picks up that the cartilage isn't doing this, and probably by some kind of signalling. And so one of the signs, radiographic signs, that you've got a progression in osteoarthritis is that the subchondral bone underneath the arthritis, underneath the cartilage, starts to pack down more bone. So it's like there's a response, there's a recognition that this joint isn't working well. And so the body response to that is to pack down more bone, but of course it's not supporting what you want is this softer tissue cartilage on top to allow the gliding, normal gliding of bones that you have at a joint. And so this extra ossification of the bone underneath isn't really helping, but it's a organic kind of response. Yeah. The other thing I think is really interesting is that other time in life when your cartilage cells hypertrophy and you get more of them is between early childhood and puberty, when you're growing long bones. So at that time, your cartilage cells proliferate. They lay down fibrous tissue, sort of like a precursor to the bone, and then the osteoblasts come in and it turns into bone, so you get longer bones. So that we've got the same biological mechanism happening in OA as you've got when you've got this endochondral ossification happening when you're growing your long bones. But you want that when you are growing your long bones, but it's not so functional when you've got OA, when you've got a joint that's not turning over the cartilage.
What I might get you to do is share with me that image again so I can put it with the recording. But what I thought was really amazing about this image that Joanna showed me was there's, what would you say, the joint layers from kind of top to bottom.
4 layers of cartilage.
4 layers of cartilage. And when I saw these two pictures side by side, there's a healthy one and then there's a pathological one. And again, this like idea, what I had was osteoarthritis was like a deterioration or a wearing down. But when we look at this in a, through a microscope on this tissue and cellular level, it's nearly like there's more stuff happening in the osteoarthritic joint. There's more nerves, more blood supply. And I believe the word that you used last week was like chaotic or disordered. Like it's trying really hard, it's just doing it in a more ad hoc way.
Yeah, and it seems that some of the pain that is felt in osteoarthritis is from that nerve growth in the subchondral bone, and there's a presence of these new nerve growth factors, and they get sensitized and then they cause more.
So it's not like nothing's happening and it's all deteriorating. It's like it's all trying really hard. It's just not that constructive.
Yes.
Yeah. How hard it's trying. Yeah. And we don't need the photo now. I can bring it up at another point. Yeah. But that was just what I wanted to speak to, and it's a specific visual reference that I'll put in. Okay. We can circle back around to the what it is, but I guess the next thing to kind of touch on is who gets this? Why are we talking about osteoarthritis? Is it prevalent? Who gets this condition? And what do you know about it in terms of who it affects?
So apparently in New Zealand currently, 400 to 600,000 people suffer or experience osteoarthritis. And the expectation is that in the next 15 years, in 2040, there'll be 1 million.
Wow.
It's a hugely prevalent disease.
You can't see, but Joanna's using air quotes for disease and suffer.
Interestingly, there are some risk factors that are associated, and they seem to be slightly different with hip and knee, for example, which are the two most common ones that really impact on life functioning. It does seem that there was one report in 2017 that looked at that adjusted for age, which is thought to be a contributing factor. Like the more elderly, it's thought that your risk for osteoarthritis goes up. It's not, what's the word? It's not, it's not guaranteed that you're going to get it. Some people will be more inclined. BMI or obesity or carrying extra weight is another risk factor. Sex is another risk factor. So all those common ones were accounted for, and even so, in the last 100 years, there's been 100% increase in the number of people with osteoarthritis, age-related osteoarthritis. So BMI was accounted for, sex was accounted for, and ethnicity was accounted for. So something about the way we're living today, so they were controlled, those factors, something about the change in life today is supporting that rise. Perhaps it's the surfaces we move around on, perhaps it's our footwear, perhaps it's our muscle bulk, I don't know. I don't think it's known yet. In fact, the one thing that has been reinforced in all the inquiry that I've been doing is that we just don't really understand this phenomenon at all, but it is increasing. It's increasing with diabetes and dementia. It's one of the increasing disabilities. Likely it's going to increase, and it has big impact on people's lives, especially in two areas. Well, no, lots of areas actually. Definitely impacting my life, and but at people of working age, it's interrupting people's ability to do their work. And young people who do have an injury like ACL will have a 50% chance in 10 or 15 years to get trauma-related development of osteoarthritis. So if you have a 22-year-old rupturing their ACL, there's a 50% chance by the time they're 40 that they will get early osteoarthritis. So that same process, that same pathogenesis happens as a result of an injury. So there's risk factors that are modifiable, and there's risk factors that are non-modifiable, thought to be non-modifiable, like genetics, which is a really big one for hip. Up to 60% is thought to really boost your chance of getting hip osteoarthritis. So genetics, sex, age are sort of non-modifiable. And then you have things like BMI, injury, that are modifiable, or, yeah.
When you say sex, my natural intuition is that it means like women would probably get it more than men. Is that the way that it would swing between those two?
Yeah, thought to be 10% more.
10% more in women. You've kind of touched on them already, but I've got this note here about the classification. So when we were speaking last week, you were talking about the difference between how different osteoarthritis is structured, as classified. I've got weight and genetics written down.
Yep.
What one am I missing?
Weight, genetics, as a result of injury.
Trauma.
With hip, there might be structural things like hip dysplasia if the acetabulum is sort of smaller and there's a chance of dislocation and things. There could be occupation. Farmers apparently more likely doing heavy loading with their bodies. So female, occupation, age, previous injury, obesity, structure, genetics.
You can see how over time this condition's already increased, but how it will increase more, because they're pretty broad scope contributing factors, aren't they? It's hard to avoid a lot of these things that we're discussing. So tell us a little bit about sort of the formal signs and symptoms, or what would happen into getting, what process would go into to getting a diagnosis of osteoarthritis. And would you like some chai tea? And I also have a chair if you felt like sitting on a chair at any point.
More recently, there is definitely a change in response to osteoarthritis because of 20 years ago, 10 years ago perhaps, even actually more recently, people would end up the first consult that... What was your question?
It was signs, symptoms and diagnosis.
Diagnosis. So a person might be referred, if they go to a GP and they said that they've got hip pain, they would be directed straight to a surgeon. They might be given some palliative care, some pain meds, some kind of medication to deal with the pain, and they'd go straight to a surgeon. And then in Australia, in New South Wales, they were approached by the government because they had so many people waiting so long for hip replacements or knee replacements, and they wanted to develop something else that could look after those people while they had to wait a year or 18 months. And so when these people, when they were responding to this, they realised that people were ending up in front of a surgeon with an X-ray, having had no other intervention, no other treatment offered to them apart from a replacement. So the diagnosis then was done according to this X-ray, an X-ray or an MRI. In more recent time, there has been repeatedly shown that there's not a strong correlation between what's happening on an X-ray and someone's lived experience. So more recently, the diagnosis is not concerned so much with the structure or methods of imaging the structure, but is on those two things, pain and function. How is this person experiencing this, and what's their relationship with their pain? Yeah, so diagnosing it is, I want to say one thing, that whole idea of kind of ending up in front of a surgeon, osteoarthritis is a 30-year disease process normally. But what happens is that the treatment is offered in the last 3, 4, 5 years or something, and that's real later stages. So there's been a realisation that this is just unsatisfactory, and that really we need to take a broader scope and look at actually earlier factors and think about, especially with the modifiable factors, looking at how we can interrupt this process.
That leads on nicely to the next question, which is what are the treatment options? And I do wonder if this is a good time to talk about the compression element and being a monkey.
All right. Being a monkey. Okay. So if you're a shark, you're not at risk of osteoarthritis.
Because you have a cartilaginous only skeleton.
Because you have a cartilaginous
which I have no idea about.
Only skeleton. And if you're a sloth, and sloths hang from trees, they have an osseous skeleton. They also will be at little risk of osteoarthritis, because the three things you need for osteoarthritis are you need to have cartilage, you need to have an osseous component, a bone component, and you need to have compression. So the thing about sloths is that they live with distraction. They live with distraction. So our joints, our synovial joints...
So that would be saying that they don't do much weight bearing in their...
No, and their joints...
Sort of live in traction. Yeah.
They live in traction, so they're, not much weight bearing, and their bones are, slightly pulled apart.
Yeah.
As compared to drawn together.
Yeah. And so we have cartilage, we have bone, and we walk on our feet.
We do.
So that leads us to compression.
Yeah, or even with the hand,
Of course.
even the fact that we have an opposable thumb means that we've got a highly mobile joint here, and that exposes it to more compression forces. Yeah.
So it is a compression pathology.
It's a compression pathology, but at the same time, if you think about the structure of a synovial joint, and this is one area that there are two opposites sitting on the same plate.
Yes.
But when you think about a synovial joint, the cartilage surfaces of the bones, of the meeting bones, as we said, don't have blood supply, don't have a nerve supply. They rely on the compressive pressure of the fluid between the bones to actually supply them with nutrients. So compression is the agent that's a component of developing osteoarthritis, but on the other hand, it's also the thing that normally feeds the cartilage.
So it's not a good option to just hang out like a monkey for us. It won't.
I don't know. I feel quite tempted. I do, and I have put myself over a chair recently. Yeah, it feels good, and there
could be something in it.
And and the interesting thing is that it feels like the joint wants more traction.
Yeah,
but as I was mentioning to you before, I have seen a video of the force you need to actually distract a hip joint. Yeah. Like with the suction of the synovial fluid, you need a lot of force. It's like it's not like you can just pull it out. Yeah, it's not quick release.
So short of hanging out on the jungle gym all day long, what are the treatment options? And you were alluding to before saying that maybe the treatment options we have at the moment, we're getting to them way too late in this osteoarthritic phase. So what do we do now, and what, with your finger on the pulse, do you think will be kind of treatment strategies in the future?
It seems like the general consensus is looking at a holistic approach to a person. And that's sort of twofold when I think of that. One, and I think this is really important. One, it's recognising that every single person with osteoarthritis, it might seem to be the same thing, same pathology that's happening, but in actual fact, you've got a human who's having it, and there's a lot of features about that human that might be seen to be not modifiable, but contributors or play into someone's experience. So the holistic approach includes things like education around what it is, that it's not a bone on bone, that it's more of a biological response of the body. Movement and exercise. On the one hand, the two types of it, like to strengthen some kind of strength component and some kind of aerobic component. Strength component to boost the muscle support component of what's happening around our joint, so quite local, and then an aerobic component because of the reported and the well-known advantages of having really making your system kind of move in terms of cardiovascular health, mood, agency, lots of things. But really interesting is that, so there is a group in Denmark who came up with this program called the GLAD program, Good Living with Arthritis Denmark. It's a program that has been moved out of Denmark worldwide to physiotherapists. So you can only train in this if you're a physio, and you can only deliver it if you're a physio. And one Danish guy, interestingly enough, who is a physiotherapist, decided that most of the exercise studies that have been done into osteoarthritis never have a control. They're just themselves, and then they're evaluated in and of themselves. So he thought, no, it was time to actually put a comparator in just to see how it stands up in the real world. So he designed an equivalent study of, so the GLAD program is an 8-week baseline program, 2 weeks of education, and then you meet with the physio. I think you might actually meet in a group situation. So there's lots of things involved there. There's kind of like a relationship with a health provider. There's a group kind of feel. There's support. The provider's probably being really good because they've got to record everything, so you're getting a really nice treatment. And the equivalent arm that he put in the study was a 4 times saline injection, 5 ml, so a teaspoon, into a knee joint every 2 weeks. So week 1, week 3, week 5, week 7. And the people in the study, there was 200 people in the study, and 100 in each arm. The people in the, I can't remember whether they were allowed to choose which arm, but they were equal amounts. The people in the saline solution arm were told that it was just saline, so wouldn't do anything, but it would probably make them feel better, because they wanted to give a positive vibe to what was happening. And do you know, there was no difference. There was no difference in that both groups had a 0.8% or something, I don't know that amount, but both groups improved, so both were seen as a good thing, but no difference between the two. And so this was quite interesting for people who had just really been pushing that, you've got to do the exercise and you've got to do it in this way, and this is the way. The GLAD program is the thing you need to do. And so what the authors, how they made sense of those findings was just recognising the heterogeneity of people and a disease process, so that some people might really gel with the GLAD program, but other people might just think, I don't like this kind of way of doing things at all. And so it was like, now we have to be, in terms of offering someone some things to do, they've got to someone has to find things that work for them. They have to find a movement process, hopefully that they can take it up to an aerobic level, and that works for them, so that you get their buy-in, they're doing something they want to do. So that's kind of interesting.
It's so interesting.
Yeah.
And what you're saying there is that, what you're pointing to is that it's not just about the load and doing the exercise.
Yeah.
You can get better, or you can feel better.
Yeah.
Without that.
Yeah. And so that's sort of looking at the exercisey arm, but recognising that there's a whole person, is that there's a growing realisation that someone's pain experience is influenced by a lot of things. Mood, sleep, diet, lots of things, and history, the sense of self-agency, the sense of positivity. And so each of those things actually needs to be incorporated into a treatment plan or into a management plan, because not all of us, I'll just put us in as someone dealing with this, not all of us will actually end up at end stage needing to have a hip replacement. They've when people are there's been been studies that have looked at exercise and diet, looked at these different ways of working with it, and their pain experience has really changed, and so much so that sometimes they look like they're having a remission. Yeah. So there's good evidence to support that. Finding a good exercise program, dealing to your sleep, dealing to your pain meds, I'll talk about pain meds in a moment, can actually really interrupt the pain experience, or mitigate the pain experience, and change the way that it's affecting your functioning.
All right, well, hit me with what else you've got about broad topic, osteoarthritis. They're all my general questions about what we're dealing with and what the outcome is. So, do you want to talk about pain medication?
I just want to talk about the biological side of the
I'd love to
process again.
Do you want to try?
Yep. I feel like I'm having this experience 10, 15 years too early. I seriously think that in 15 years it's going to look different.
Yeah.
And I think the thing that's going to look different is that the biological understanding of the pathology will be advanced, because there's something at a cellular level going on that we don't completely understand here, and there's a lot of research going into different parts of that. And so they're looking at tissue. What is the change in tissue, and what are the things that are in it? This is just very layperson, but what are the things that are in the tissue that are different from a healthy joint? And there are these biomarkers, or these molecules. When a chondrocyte is doing that growing thing that it does when you are growing long bones, when it's doing it in a osteoarthritic sense, it's releasing molecules that are actually inhibiting the regeneration of that cartilage. So they're counter to the regeneration of cartilage. It's almost like the cells think cartilage isn't up for it here, we've got to build bone. So they're actually putting down more fibers than is needed. And so in a laboratory setting, what they're finding, they're working a lot with mice, I have to say, but in the laboratory setting, they're finding that there's evidence of cartilage breakdown, and a lack of cartilage breakdown and a lack of cartilage promotion. So they're finding these agents that are just smushing around in there, and so a lot of the research is into, okay, can we put something into this joint that will negate those things and boost the ones that aren't there. And interestingly, they've done this with animals. They've been able to not, air quote, cure osteoarthritis in an animal, but they've been able to, and this is done by a vet, so I'm not sure how big the animals were, but they've been able to halt the progression of the osteoarthritis, because it is progressive. It's not that everyone's going to get it, but once it's there, it kind of, you can see that if you've got these swirling round components, they're just going to perpetuate this kind of like degeneration of the cartilage, the swelling of the synovium, and the building up of this bone and all these extra nerves and blood vessels and the subchondral layers. They can stop that process, but the interesting thing is that doesn't mean, so it doesn't progress, but it doesn't mean that that tissue is going to go back to a healthy tissue. So they can't reverse it. They haven't discovered how to reverse it. Who knows if they ever will do that, but not in my lifetime probably. But they can certainly read what's happening at a molecular level, adjust for it, and halt that process. So I imagine there'll be more of that going on. They also want to use what they're seeing in the biomarkers to determine who's going to progress quickly and who's not, and then you'll be able to give some targeted treatment, metabolic treatment, to the people who aren't going to progress quickly, just to support that. So that's just the going along on the biological level. Really interesting that it's not wear and tear in that there's just scraping down off the top. It's like the whole inside of these tissues is, in a way, I feel like it's doing its best, but it's like just putting its effort into the wrong thing. So I don't quite understand the genetic component of that, except that perhaps some factors, some of these biomolecules, somehow seem to be facilitated in someone who has a genetic predisposition. I have a father, an uncle, cousin, and a grandmother who all had issues in the same place. And the last chemical thing that I'd like to say, which is really exciting too, is that the medications for pain that people have given, traditionally it was sort of paracetamol in the first instance before moving on to something a bit more high-end. Apparently the opioid crisis in America, because of opioids prescribed for pain, is just off the charts with consequences and not really dealing in any way to how someone is experiencing themselves. And it seems that even paracetamol long term is what might seem to be quite a mild pain mediator, is no better than a sugar pill. And actually it's not a good thing to be taking long term. Glucosamine, or what's the other one beginning with C, that are common things that people have, that I have associated with, okay, let's boost my joint by putting something in, even having a knee arthroscopy. Treatments that have been used in the last 10 or 15 years are being shown to be not clinically beneficial over just not doing anything. And it seems like there is interest, though, in some products that seem to be more naturally found, like there's a tree bark called cyanogenol, which is something from a pine tree. There's boswellia, which is like Indian frankincense, and there's curcumin, which is something from turmeric. So these are three things that don't have very good evidence, not strong studies yet supporting their use, but they seem to be really good in terms of they've been found to be useful in other conditions like heart conditions or other arthritic conditions. And and they don't have the side effects. So there seemed to be a lot of interest in what some more naturally based products can do to affect the process, the pathology.
Is it worth having a quick chat about collagen and collagen supplements? Just because I can see the rabbit hole.
Right. Okay. So,
because collagen wasn't on the list there of the things you see, was it?
No.
Tell me why.
No. So collagen is, one of those foundational proteins that you think it's really good to put into anywhere that needs a bit of structure and support. But
because our connective tissue is collagen.
Because our connective tissue is collagen.
We've got it in us.
Yeah.
And so when you see it on the shelf, a supplement that says collagen, it only makes sense.
Yeah, our bones, our cartilage, our synovium, our capsules, everything has collagen. So let's boost our ailing joint
some collagen.
With some collagen,
but not so fast.
No, not so fast, because as somebody said, you might take it in your mouth or something, but how's it going to go where you really want it to go? And so it looks good, and it kind of like had an appeal, and I do have a jar in my cupboard.
I do too.
And my jar has vitamin D and something else that seems to be good for me in there as well, but I don't know. And the other thing about the curcumin, so curcumin's from turmeric, and turmeric has in the last 5 or 6 years, has been maybe 10, has a reputation for being anti-inflammatory. And but apparently, if you're taking fresh turmeric in your chai or your something, or you're taking powdered turmeric, you would need to take 2 kilos per day to be able to absorb it. And if your poo is not turning yellow, you're not absorbing it.
Got it.
Yeah.
Okay.
So again, it's a matter of what goes in. It's not just taking it in. It's not going to do what you might wish for it to do. But that's why those 3 things are seemingly really interesting. They've had a use in Chinese medicine and things for a while, but there was actually, I saw this morning a 2022 meta-analysis on Boswellia. So, don't know, I might go and see if I can find some Indian frankincense.
Another thing to do.
Yeah.
Okay, well, what else is on your, have you got anything else on your piece of paper that we haven't touched on yet? Any little memory cues, something to jog that you'd like to share? Yeah.
Well, I think for myself, something that Lorimer Moseley said, and I'm probably not saying it in the way he said it, but it's something that I really do believe in the adaptability of life. I do believe that it was something like, he said something like, biological tissues have an irrepressible adaptation to what's happening. It's like osteoarthritis is not a passive end stage disease. There's an active process happening, and it is geared to try and respond to what's happening. So if you have a joint that's not up to the task, its functional task, there is an impetus to do that. It's just that there might be too many things happening at a cellular level to be able to garner a really reversible, to reverse what's happening. So yeah, I think just the joints have a capacity for repair, and they're alive. Yeah, they're living tissue.